My name is Ami Banerjee. I am Professor of Clinical Data Science and a consultant cardiologist at University College London. And I'm also a trustee of the South Asian Health Foundation. It gives me great pleasure to introduce my friend, colleague, mentor, Professor Wasim Hanif. Wasim is a diabetologist. He's Professor of Diabetes and Endocrinology in Birmingham, and he has various hats that he wears, including at the BMJ, including in research, in various all-party parliamentary groups and so on. But today, he is going to be sharing his experience and his expertise in how we can do better at reaching so-called harder to reach groups, the age-old question of whether it's the people who are harder to reach or whether we're not trying hard enough. Wasim, thank you very much.
Thank you, Ami, and thank you very much for having me here. And good afternoon, everyone. So good afternoon, everyone. It's an absolutely great pleasure to be here with you and to share a few thoughts, both in terms of what are the challenges in what we call hard to reach group, or are we not reaching hard enough? It is quite a provocative title, and I like it that way. What I'm going to be doing today is to share my experiences of over the last 2 decades working in the health inequalities and trying to give a kind of a picture about what the challenges are and what has worked and what has not worked. So I'm not only going to talk about the challenges, but also I'm going to focus on solutions. A good part of my talk is to try and work to focus on the solutions to see how we can do this better, and we have to do it better. One of the important things for us all to understand is when it comes to healthcare, one of the greatest innovations, or what we can call the healthcare setups of the 21st century across the globe, has been the brilliant NHS. And we all work in the NHS and are really proud of it. NHS was set up in 1948, mainly to serve a white British population. And all the structures that came in to support the NHS, be it the medical schools, the Royal Colleges, the GMC, and the rest that followed, have all been are still in that phase of the NHS where it is for a particular population. And somehow we have come to understand that it is a one-size-fits-all service. Although a lot of changes have happened, and especially in the last decade, and especially in the pandemic and post-pandemic, still I think there are a few challenges as we try and deal with a much more diverse population, which requires a completely different service and a completely different language of health. And this challenge is not only of the NHS, but it is also of its structures that support the NHS, be it research, be it academia, be it medical schools, be it Royal Colleges, be it the GMC. So today I'm going to just take you through the journey. Now, the first slide I'm going to show you is to give you the two stories of two Mrs. Bs. Now, this is something which I had a personal experience about, seeing two Mrs. Bs in a health setup. And for people to understand it, it is important to know that most of the people providing this service for these two patients, two people with diabetes, were from the ethnic minority communities. So one conversation is a nurse walks into the room and says, "Oh, we have got the Mrs. B, the usual one. She is refusing insulin, and you know how these people are." The second conversation of another Mrs. B of the same age. Oh, we have got Mrs. B. She's so scared to go on insulin. She is she's terrified of needles. I'm not sure what we can do to help her. Now, the reasons it is important to look at these two conversations is both the patients from a clinical perspective are the same. But the reason we are getting a different clinical interpretations of these two patients is to do with the structures of the NHS or the communication of the NHS, which treats these two people differently or does not understand the barriers of these two people. In one case, it does, because that's the way it has been set up. But for the other person, the reasons that are given for the person to go on insulin and her apprehensions of going on the insulin are not fully understood, and that leads to a wrong interpretations. Now let us see what can be done to really handle this and what these barriers really are. Now, this is probably one of the best definitions that have come around for health inequalities, and this was published in the BMJ in 2001. And it basically says that health inequalities are avoidable inequalities that are unfair or unjust. It is as simple as that. And therefore, because they are unfair or unjust, they need to be tackled and handled, and we all have a responsibility in doing that. Now, what is the reason why these health inequalities occur in the NHS? Now, one of the important reasons, I think people tend to blame it on structural racism or institutional racism and all that. But things are much more complex, and it is very important for us to understand, if we are to tackle this, to really go into the core of the problem. Now, to do that, let us look at research. And I'm going to slightly focus on the diabetes research because that is my area of expertise. Now, this is a population of the world by its population. So we're looking at a global perspective. And as you could see, the bulk of the human population is in the Indochina region, with nearly 1.6 billion in what we call the South Asian region, as we're celebrating the South Asian Heritage Month. And if we just look at the prevalence of diabetes, again from a global perspective, we find that the largest portion of people with diabetes, again, live in South Asia and China. So that is where the diabetes is. And this is talking mostly of type 2 diabetes, and these are where the issues are. Now let us look at research and publications, which actually help us to guide treatment of these patients and help us to interpret and both interpret as well as implement the evidence-based medicine. So if you look at the list of publications that have come from on diabetes by World Cohort, we find most of the publications are either coming from Northern America or Europe. There is hardly any publications coming from Indochina, and there is hardly any population included in the research. So one of the first elements that we are missing in the whole jigsaw is there is very little research and evidence base in this population for us to understand and implement. We did this paper a few years ago, basically looking at representative people of South Asian origin in cardiovascular outcome trials for glucose-lowering therapies in type 2 diabetes. Why this paper was important was that these 12 studies that we looked at have really helped us to shape the guidelines for managing diabetes across the globe, including the NICE and NG28 guidelines are based on these studies. But if you look at the South Asian cohort in this trial population, it is severely underrepresented. There were hardly any South Asians, or the numbers were very much lower. And one of the conclusions that we reached was that clinicians should exercise caution when generalizing the results of trials to their own practice. Now, one of the important elements that comes in whenever we talk about health inequalities or hard to reach groups is, what are the hard to reach groups? How do we define them? People have used the arguments of between deprivation versus ethnicity. Now, I think this is a very kind of a false perspective that is being created. One thing is sure, that if you are poor, you do worse in terms of your health outcomes. And it is probably one of the biggest drivers of the social determinant of health is deprivation. But I think what is even more important to understand is that there are other factors other than deprivation that contribute to poor health outcomes. And this is defined in the Equality Act of 2010. And it looks at a number of factors. So this is the NHS requirement to provide equal accessible healthcare to these protected groups. And you could see there is race and ethnicity, disability, religion, age, sexual orientation, gender realignment, etc. But there is no deprivation here. So, from a legalist perspective, when it comes to inequalities and hard to reach groups, these groups are a protected entity. And this is something very, very important for us to understand, rather than going into this quagmire of deprivation versus ethnicity. Uh, these are some of the groups that need special provisions when it comes to health. Now, the last decade or so has been a great time for us to be in diabetes. This is a paper from 2015 or earlier than that, and it actually showed that the age of diagnosis of diabetes is very important, because it tells you how many years of life you will lose because of diabetes. So if you're able to cut that 60th birthday cake of yours and eat it without guilt, then diabetes will do no harm, because your life expectancy is nearly normal. But if you, on your 60th birthday, have got diabetes, then you lose about 6 years of your life. And if you're unfortunate to have, along with diabetes, a cardiovascular event like an MI or a stroke, you lose about 12 years of your life. So essentially, meaning that for a person living in Birmingham, whose average life expectancy in inner city areas from ethnic minorities is about in 70s, they will not be able to enjoy the retirement. But what has happened is, because of the change, because of the advancements in terms of the cardioprotective drugs for diabetes, and better management of diabetes, what we now see is, this is a very interesting paper from the Swedish Medical Registry. And what it actually shows is that if you are able to control blood pressure, diabetes, give them the right treatments, give them right things for cholesterol, have all the care processes, you end up adding 8 years of life. 8 years of life. Instead of losing 6 with diabetes, you add in 8. So you get 2 extra years. So if the management of these patients is done properly, you actually gain life years, which is absolutely brilliant. But let us try and understand what is happening for people with diabetes. Now, this is a study that I was involved in about a decade ago, probably more than that. So this is the United Kingdom Asian Diabetes Study that we set up mainly in Birmingham, Coventry, basically looking at a number of factors, both in terms of diabetes and cardiovascular. And this study did show some huge differences, both in terms of the care and the outcomes. Now, the thing that was known is that the diabetes tends to occur a decade earlier in South Asians. The diabetes control was poorer, and etc., etc. And we also found that the ethnic differences in terms of HbA1c was about 1% between the South Asian and the white European population. And this was actually maintained over a period of decades. So again, suggesting that the South Asians start with a higher HbA1c, and this is and this is continued over their lifetime period. But one of the most striking paper that came out of the United Kingdom Asian Diabetes was when we look at death and cardiovascular disease. What it showed that the South Asians, when compared to the white Europeans living in the same in the same deprivation index, died a decade earlier, and that is absolutely shocking. Now, this is a recent publication showing the data from 2017 to 2019. Again, this is from before the pandemic. And what it really shows is that when it comes to cardiovascular disease and diabetes, still the South Asian communities tend to do much worse than the white European communities, both in terms of the uh, causes of death as well as disease like heart disease, cardiovascular disease, and diabetes. And this actually shows um, uh, the other big important thing that happened. So this is the story pre-pandemic, but in the pandemic phase, one of the most striking things that we found was when it came to the COVID death, there was a higher death that was seen again in the South Asian communities, in the black in the black communities, and this was mainly driven by COVID related deaths. Now, the question really, what we need to really focus on is that when it comes to outcomes of people of ethnic minorities and South Asian heritage, there are two things that are emerging. One is when you look at the hard outcomes, especially when it comes to cardiovascular disease and long term conditions like diabetes, they tend to do much worse than the white Europeans. They do better when it comes to cancer death. So, this is something what I usually say, that if you're a South Asian and you survive cardiovascular death in your 60s and 70s, then the chances are that you're going to live longer because your risk of developing cancer is less. And this is quite a great opportunity for us to target this population which develops diabetes and cardiovascular disease a decade earlier. And if we are able to target and message and reach these communities, we can make a big difference in terms of their outcomes. Now, what COVID did was it just exacerbated the health inequalities that already existed in these communities, both in terms of deprivations, both in terms of messaging, both in terms of the access to the healthcare and the language that is used in the delivery of healthcare. Now, let us just focus on another thing which I just talked about, research. And why is research so important in these communities, especially when we do large clinical trials and implement them? So there was a very large clinical trial that was published in the Lancet. This study is the direct study that was supported by Diabetes UK. And I have to hold my hand up and say that it was a part of the board of Diabetes UK. So this was a £5 million grant from Diabetes UK to run a trial to see whether it's possible to cure, in brackets, or have remission of type 2 diabetes. And it was a brilliant study. People with type 2 diabetes, within 5 years, they were stopped and put on what is called essentially 800 kilocalorie soups and shakes diet. And the results were great. So the patients that lost nearly 15 kgs body weight, 86% of them, the diabetes went into remission, which means they did not require any treatment, and the HbA1c was normal. Following this, the NHS uh, in its right mind, decided to implement this thing as a part of the NHS type 2 diabetes remission program, and this has been implemented across the country. But one of the drawbacks of this trial, which was not picked up at the time when the trial was approved, or it had this grant, or it was implemented by the NHS, was to realize that nearly 99.9% of the patients in this trial were white Europeans. There were hardly any South Asians or people from the Afro-Caribbean communities. Now, once this trial was implemented nationally, this is what it actually showed. It showed that the uptake for the NHS diabetes remission, or the people who went into remission, was just less than 10%. And the people in whom you could see the remission of diabetes were exactly the same people who were in the clinical trials, usually white, middle class, females. The remission rates in the ethnic minority population was very low. So what this actually showed is that when you have a national program that you're going to implement nationally, it is very, very important that it should be a representative population. So whenever we do an impact of any clinical trial, which is adapted either by NICE or by the NHS, there are two things looked at. One is the clinical effectiveness, one is the cost effectiveness. But I think we also need to look at a population effectiveness, whether the clinical trials has got representative population of the UK. And as we all know, the 2011 census shows about 11% of the populations to be from ethnic minorities, probably a bit higher in England than in other parts. Now, before we look at what are these hard to reach groups and why we find it hard to reach them, and what the challenges are. Now, one of the most difficult conversations that I've had over my 2 decades in the health inequality field is to try and talk to my colleagues, usually white colleagues, to try to explain to them the challenges of hard to reach. Because one of the difficulties is that whenever this conversation is started, people tend to get defensive because they feel that they're being accused of either being racist or not bothered, etc., etc. So all the feelings are of negative feelings. What is very important to really emphasize here is it is not about the individual that is important, that is perhaps the barrier. In terms, it is the systems and the structures that need to be changed. So what are the challenges of structures? So how does the system or the NHS identifies me, be it in academic circles, in terms of research, be it in terms of the NHS, be in terms of what is reported? One of the biggest thing is that we tend to use a lot of words, be it BME, BAME, ethnic minority ethnic group, person of color. I've even come across this new term called BIPCO. But is that what I am? Now, I think that most people of what you call ethnic minority communities don't identify themselves with any of these terms. So, what is the term that I would want to identify myself? So, who am I? I'm British. What is my heritage? My heritage is Indian. So, I'm British Indian. If you want, you can add in a religion there. But that is my core identity. And it is very important for these to be recognized. Once you club people together, what really happens, the outcomes of, say, British Indians are probably better than British Bangladeshis or British Caribbeans. And this gives a very skewed picture. And it doesn't really represent what is happening with the communities. And for researchers, when they look at the whole of the ethnic minority, they can come up and say, oh, these guys are actually doing better than the white European population. But that is not the right terminology to use. So I think it is very important to understand the terminology, because still we don't understand the terminology, we will not be able to reach these communities. The second important thing, which is again one of the biggest barriers, is the general assumptions is that the ethnic minorities, again with brackets, do not speak English. Now, the 2011 and the 2021 census actually shows when it comes to South Asian communities who have been living in this country for about 3 generations or 4 generations, 92% of them actually can speak or understand English. The second most commonest language that is spoken in the UK now is Polish and not Urdu or Punjabi. Now, again, this is again an inherent bias in the system that whenever you're dealing with ethnic minorities, the first thing is said is, if you want to reach the communication with them, you need to translate in about 10 different languages in 10 different scripts. Now, as I mentioned to you, what the 2011-2021 census data is showing is that if you are not able to read or write English, it is very unlikely you are going to be able to read or write any other language. So this thing about just it being an issue of language is wrong. It is more an issue of communication and cultural competence than language. The second question is, why am I here? And for this, we need to probably look at the migration of South Asians. And this is a part of my MD thesis. And I always use this, again, a provocative quote by Suketu Mehta, who famously said, "We are here because you were there." And this is around the post-colonization. It was mainly for post-war rebuilding of the nation, migration from subcontinent, either side of Punjab, where most people came from both India and Pakistan, Sylhet in Bangladesh, and the East Indians who came from Africa and the Sindhi. Along with it, you had the white collar migration, as we know that nearly a third of the workforce of the NHS now is of South Asian heritage. Now, the South Asians as a people are probably one of the largest ethnic groups. And again, it is very important to try and get these things out around race and ethnicity. So ethnicity is the term of culture of people in a given geographical region, including their language, heritage, religion, and custom. So South Asians are classified as an ethnic group. They're probably one of the largest ethnic groups in the world, with about nearly 1.6 billion people, and a large South Asian diaspora of nearly 37 million, scattered across every part of the world. And to really understand the South Asians, again, I quote Suketu Mehta, who said that we are a nation of many different countries. So the basic ethnicity, despite there being many nations, many cultures, many continents, the basic core or ethnicity of this is the same. Now, one of the again the issues around what is happening in terms of the care that these patients are receiving, and again you can see post pandemic there has been a huge drop in terms of the care that is being received of people from ethnic minorities from both type 1 and type 2 diabetes. Now, in the last part of my talk, I'm going to talk about the solutions. Now, one of the most important solutions that we are going to be really looking at, to me, is to try and develop a culturally competent healthcare systems. And that is the only way we will be able to reach all our communities. Now, one of the best definitions of what is cultural competence I have found is from Betancourt and Carrillo. And they said the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet patients' social, cultural, and linguistic needs. Now, one of the important elements, and this has been again one of the failures both of the NHS as well as of our academic institutions, is that we have not really understood cultural competence. For a very long time, when I was involved in our academic research, everybody used to talk about cultural sensitivity. Now, we need to understand what is the difference between cultural sensitivity and cultural competence. I'm going to give you an example. So, if you have a pregnant Muslim woman who's got a large for size baby who's fasting, who wants to fast during Ramadan and is on insulin, now a culturally sensitive healthcare system will allow her to do so. While a culturally competent healthcare system, but the healthcare provider, irrespective of who they are, knows enough that this person should not be fasting, both from an ethical, religious, or social reasons, and they will be able to challenge and change their behavior. So, what is culturally sensitive healthcare system? It is passive. It accepts whatever the person says. While the culturally competent system is active. Culturally sensitive healthcare system is patronizing, while competent healthcare system is understanding. Culturally sensitive healthcare system is accommodating, while the competent one is challenging. One is behavior reinforcing, and the other one is behavior changing. Culturally sensitive healthcare system does not require any training, and it is just let the people do what they want to, while the culturally competent systems requires training at a very initial level, from the very initial levels of medical schools, nursing schools, to help the medical workforce really understand what the various needs of the communities are, what the various languages they have, and how they can be addressed. Now I'm going to look at some of the work that was done by a lot of organizations, including South Asian Health Foundation, around vaccines, and use it as an example of good medical practice and how this could be translated for other conditions, especially chronic conditions like diabetes and cardiovascular disease. One of the biggest challenges after the COVID was, once the vaccines became available, was this concern about vaccine hesitancy, especially around the ethnic minority communities. The initial data actually showed that the uptake among the ethnic minority communities was much lower. And this was actually true in certain communities like the Black Caribbeans, Black Africans, and the Pakistani and Bangladeshi communities. And it was thought how this challenge could be met, and got the health planners really concerned. And this was a kind of a survey that was published, which actually showed, in terms of people uh, wanting to take the vaccine or really enthusiastic with the vaccine in the ethnic minority communities, initially was only 13%. And by May and by in January 2021, when the first vaccine was given in Coventry, and by May it had gone up to 50%. At that point, it was realized that something needs to be done. And a lot of organizations, along with Department of Health, say JCVI, started working as to how we could develop a language that is culturally competent to reach these communities. One of the important things that was identified, what was the barriers to vaccine uptake. So one of them was this perception of risk, low confidence in vaccine, distrust, access barriers, inconvenience, socio-demographic context, lack of vaccine offers, and lack of communication to trusted providers and community leaders, and the disinformation that was spread through social media, especially for people of South Asian heritage, where social media platforms like WhatsApp added to confusions and barriers, right from male impotency to infertility to the whole race being wiped out, were very much circulated. So, how did we overcome these barriers? What are the lessons that we can learn from here that we can translate into other areas? At the South Asian Health Foundation, we were quite active and really wanted to engage. So I still remember a conversation I had around, it was around the 1st of April. So the lockdown had started, and after a long time, I was back on the front door managing a full COVID ward of patients in Birmingham. And one of the first things I noticed was that my ward with very sick COVID patients had an overrepresentation of people from ethnic minority communities, and it being Birmingham, most of them were from South Asian heritage. I had a conversation with a very good friend of mine, Professor Kamlesh Kunti, who has done some amazing work on COVID in ethnic minorities and part of SAGE. And I actually told Kamlesh that I'm seeing a large number of patients from ethnic minorities that are overrepresented on COVID wards. And Kamlesh actually talked to other people and then came back and said that, yes, this is the initial report we are getting. At the same time, the ECNR thing was published, which again, it showed an overrepresentation of people from ethnic minorities in ITU. So this was one of the first editorials which we did probably around the same week, which was published in the BMJ. And this was probably one of the first editorials globally that looked at ethnicity and COVID and said that these patients have been disproportionately impacted by COVID, both in terms of the seriousness of disease as well as mortality. We also started looking at the vaccination, and this is again one of the papers that we did, which basically kind of forewarned the planners that if they want a widely accepted vaccine rollout nationally, it should have a culturally competence, an important element attached to it. There were a lot of training webinars that were done by SAF and other providers, and it was basically to really help and aid healthcare staff to recognize the importance and the role of trusted sources for health information in minority ethnic groups, which are kind of different from the traditional sources of information. And also, it was very important to really understand and dispel the myths and concerns and not just rubbish them off. Vaccine hesitancy was not similar to being a vaccine denier. It was also important to use different platforms. So we used a lot of multilingual, non-stigmatizing communications. And this had various formats to it, right from videos to audios to infographics, to try and explain it to people. So it was not, it was not what you call word heavy. It was easy reading. It was infographics, and multiple communication platforms were used to communicate to people. Again, vaccine endorsement was taken from trusted sources, be it community leaders, faith leaders, local healthcare providers, mosques, temples, gurdwaras were involved, and digital platforms and innovative campaigns were done. And these are some of the work that was done across the globe, right from people tweeting when they had their vaccines to the mayor of London working with South Asian Health Foundations to people of standing in the community talking about the vaccines. And this actually, and also it was realized that other than the issues around the communications, there were some physical barriers for people to get the vaccine. So most of these people from ethnic minorities lived in lived in deprived areas where it was very difficult for people to travel, especially with lockdowns and other things. So it was not important for the vaccinations to go near the communities. So be it in the mosque, local communities, mobile units were used to reduce the physical barriers. And these were some of the messages that came from religious leaders. Birmingham Mosque, not far from where I live, became the first in the UK to offer COVID vaccines to all communities, and I think that was very good and brilliant. At the same time, there was a lot of religious concerns around vaccines, especially whether to take vaccines during Ramadan and stuff like that. And this was again some of the stuff along with my colleague Sarah Lee that we did, both in terms of Lancet publications as well as the infographics to try and explain about fasting and COVID vaccinations and how could this be done. So, how did we do in the end? I think in the end we did very well because the uptake of vaccines improved, especially in the South Asian communities, in the Pakistani and Bangladeshi communities, where the uptake was initially very low. There was a huge increase in the uptake. So, what I was trying to explain here is that once there is a will to engage with the population and the tools are available and the resources are available, it is possible to have the most difficult conversations to the communities. And there's nothing like hard to reach communities. It's not hard to reach communities. It is the structures that are important to reach these communities, and we need to work and develop these structures. These are some of the stuff that SAF has done in terms of the COVID-19, both globally as well as in the UK, in terms of the 10-point plan and trying to put in things to protect the communities. So in the end, I would probably think that how can we reach what we call the hard to reach communities or what they call the unheard of communities? I would probably make these set of recommendations. I think the first thing we need a proper semantics and terminology, which means we need ethnic coding, both when we are recording data with the primary care or in public health or in other sources. And clubbing of all ethnic minorities, be it in BAME or BME, does not work. We need a legal framework for representative populations in clinical trials. Here, I'm not talking about political correctness, or here I'm not talking about adequate presence of ethnic minorities. What I'm talking about is representative population. As we know that nearly 12 to 15% of the population, depending on which part of the UK live, is from ethnic minority communities. So it should be a legal requirement, as it is in the USA, that any clinical trial or any drug or technology that is approved either by MHRA or NICE should have this representative population. The impact assessment of research, once it's implemented, should be on the whole population, should be a mandatory requisite for funding by large funding bodies. And culturally competent language and training should actually start from medical schools and should be, again, something that is compulsory for all staff, academics, as well as researchers. And finally, the NHS funding and things like COF and other initiatives should again be based on population-based outcomes on the whole population. And this is probably my last slide, which is quite self-explanatory. The whole question with the equality versus equity debate is to remove those structural barriers, and that is the best way we can do it. Thank you. So there is a question that I have caught is what is being done as a preventive measures to diabetes rather than focusing on treatment. So currently, I think we have got enough tools to try and prevent diabetes. We have got one of the largest public health programs in the globe, which is the NHS Diabetes Prevention Program. Now, what this actually involves is to identify people who are at risk of developing diabetes, which is what we call the pre-diabetes, and then putting them on a kind of 6 month, nine session program on preventing diabetes, which is basically giving them advice on diet and lifestyle and making them lose 5% of the body weight. So this is a part of the NHS diabetes prevention program that has been implemented across the UK. I think that's a very good question about ghee. The whether England can't absorb it. I'm not sure whether that is entirely correct. As you know, ghee is got a lot of saturated fats, so it increases your increases your cholesterol and has a cardiovascular feature, and can also make you put on weight. But the absorption of it due to weather, I don't think so. There is any truth behind it. Yeah, I think the issue around vaccine, as I said to you, there were lots of barriers and have dealt with in my talk as to what these barriers were there and how they have been handled. Because some of the vaccines, although they were developed quite rapidly, they went through a very rigorous process, both in terms of the clinical trials and the evidence. So I think there was no compromise on the process, only the time was shortened because newer research techniques were used in terms of developing them.
Wasim, thank you very much for your talk. Sorry, we had a hitch joining afterwards, but I'm very struck by what you said about uh, harder harder to reach in terms of if versus trying hard enough. Because in my own area of cardiology, when I was at medical school, we were taught that South Asian women in particular were at particular risk of MI and less likely to be treated, and that was a barrier of them presenting. And now, in the last decade, we've seen major advances because that was flagged up, because clinicians in primary care and secondary care and the patient communities themselves are more aware of the disease, that these South Asian women are as likely, if not more likely, to say receive angiography or receive diagnosis. So it's this idea that I think it's very powerful what you said, whether it's diabetes or heart disease or COVID, that you can make a difference if you try harder. That's the message, isn't it? That you're
Yeah,
saying.
absolutely. More than trying harder, I don't think so. You need more resources. The language needs to be different. I think what has happened is that if you actually look at access as well as the whole healthcare setup, it is the same structures that is set up in 1948, which is mainly to serve a white British population. So we've got big hospitals which are very intimidating. We have got a very little kind of a primary care. Now, one of the things that I always say to people is uh, generally the language of the NHS in terms of its health communication is based on the individual. So basically, whether you're doing research, whether you are recruiting somebody for a clinical trial or giving the information, it is the individual, because the individual is the main person. In the South Asian communities, it is not the individual, it is the community that you have to the conversation with the community. So be it in terms of research, recruitment, you have to tell the community what are you doing. And once the community is able to accept it, it will accept and be a part of the research trial. So when we had these communications around the COVID vaccines, we didn't talk to the individuals, because when we talked to the individuals, we wouldn't get them. We started talking to the communities. In the Afro-Caribbean communities, the communication has to be with the family. The family has to rate. So it is the structures of the communications that are different. Uh, we have somehow got into this one because it is the individual communication. We keep on trying to have that individual communication, and that is where the barrier becomes. And then we think, oh, these are hard to reach communities. They don't be a part of the clinical trials because they don't want to be part of the clinical trials. They don't want to go on insulin. So it is trying to break that barrier with a different approach.
Yeah, thank you. What are your views on, or what should be our approach about what are called intersectionalities between protected characteristics? So ethnicity versus socioeconomic status, age. It could be homelessness, mental health. These all have almost incremental impacts, and should we consider them all together or separately?
I think that's a very good thing, because this is one thing about intersectionality. Because I was recently at ABPG and I was telling you that if you're a Bangladeshi trans person from inner city area, your average life expectancy, I don't know, is going to be in 50s. So each of these factors add in to your worst health outcome. Now, one of the biggest, I think, I'm not going to say, but an irritant that's come in both in terms of the academic research and in terms of the discourse, and this is mainly political. I'm going to be a bit political and run by a certain section of the media, is building this between deprivation and ethnicity. These are both these communities have got worst health outcomes. So it is like pitting the worst, one what you can call poor section against the other. The comparison should perhaps be more with you know with ethnicity and high socioeconomic status. And that is the reason why we are getting into this really a false perspective about, is it ethnicity that drives it or deprivation that drives it? No, it both. And when you talk about intersectionality, each of them drives it. So if you are your sexual orientation drives it, your gender realignment drives it, your disability drives it. So all these these protective characteristics kind of work together, or make your outcomes much worse.
That's really helpful. And final point, Wasim. So going forward, is there take up of the guidance that you've clearly set out there in your final slide, whether it's in terms of coding or otherwise, or what are the next steps?
Yeah, I think I'm an eternal optimist, but I think I've been more optimist in the last 2 to 3 years than I have been throughout my career. And I think there have been some real good advances. And now people are willing to listen and engage. From the time I remember when I did my first paper and presented at the West Midland Physician Association and on ethnicity and diabetes, it was really shouted or lynched to a stage where members of parliament and senior people, both in research, are willing to listen and engage with you. And I think we've made some huge progress. That doesn't mean that the work is already done. Still, a lot of work needs to be done. But now we are getting an engagement, and which really means that a lot of young academics, researchers like you, and the healthcare providers need to start engaging. And I sincerely feel that the changes need to start at the medical schools, at the nursing schools, where we have to start talking about cultural competence and culturally competent language of communication. Because we train our medical students to do a lot of things, and around the communication has become important, but we do not train them around cultural competence. And I think this is something that has to be taken up. And once we are able to develop a workforce that understands culturally competent language, there will be no hard to reach communities in the UK.
Wasim, thank you very much for your clarity. So to sum up, cultural competence is key, and there's no such thing as a hard to reach group. I'd like to thank, obviously, Wasim for his wise words and his sharing his experiences, and also to the organisers from South Asian Heritage Month, and to you, the listeners. Thank you very much.
Thank you, Amy. Thank you, everyone. Thank you. Have a good day.